Welcome to Pharmacotherapeutics for Advanced Practice Nursing Across the Lifespan. The required reading is Chapter 37. In this chapter, we will look at the function of the kidneys and diuretics. We all know that diuretics cause a loss of fluid from the kidneys, and that diuresis refers to the increased formation and secretion of urine. Let us look at the uses for diuretics. One such use is hypertension, which is elevated blood pressure. If we reduce the blood volume, we will reduce the blood pressure. This is not a one-time treatment. It is ongoing. Diuretics can be used to treat excess fluid in the lungs, in the abdomen due to cirrhosis, kidney disease, or heart failure. If we pull off fluid from the blood volume, then the excessive fluid will drain into the blood and get excreted. If we want to flush the system and remove wastes in the urine, we can give diuretics to move more urine and cause additional filtration of unwanted substances. Shortness of breath due to fluid in the lungs can be treated with diuretics as described earlier. Make note of this. Where sodium goes, water follows. We can use diuretics to move sodium out and move water with it to reduce blood pressure and total peripheral resistance to allow increased cardiac output. Special cases of diuretic use include elevated intraocular pressure, altitude sickness, and seizures. Terms you should be familiar with regarding diuretics include natriuretic, which are drugs that cause sodium to be excreted. Potassium-sparing diuretics, which are drugs that reduce the exchange of sodium for potassium in the collecting tubule, causing more sodium excretion and less potassium loss. Unfortunately, when we administer diuretics, causing desired changes in blood pressure, the body responds with counter-regulatory mechanisms. One such mechanism is the activation of the renin-angiotensin-aldosterone system, where aldosterone is released to counteract the loss of electrolytes and water. Our thirst mechanism remains intact when we use diuretics. Thirst is a driving force to increase fluid volume to maintain blood pressure. To be noted, diuretics do not change our appetite for salt. In order to understand how diuretics work and where they work, we need to understand the kidney. Let's look at the anatomy of the kidney. The kidney is composed of an outer portion called the cortex. The cortex contains the functional unit of the kidney called the nephron, which we will look at in the next few slides. Moving inward is the medulla. The medulla contains the tubules and collecting ducts. At the heart of the kidney is the renal pelvis, which is the holding tank for urine collected from the ducts. The renal pelvis empties the urine into the ureter, which then empties into the urinary bladder, which excretes urine out through the urethra. The basic functional unit of the kidney is the nephron. That is to say, the portion of the kidney that does the work of the kidney, such as removing wastes, is the nephron. The nephron exists in the cortex and extends the tubules into the medulla portion of the kidneys. The nephron is composed of the glomerulus and some tubules. The glomerulus is where it all starts. The renal arteries bring in systemic blood, full of stuff, including wastes, electrolytes, glucose, and water, as well as some drugs possibly. The arteries provide this blood under high pressure to the glomerulus, which is a conglomeration of capillaries surrounded by a capsule, namely Bowman's capsule. Think of Bowman's capsule as a bathing cap, the renal artery as a hose, and the glomerulus as a soaker hose. The hose and the soaker hose are inside that bathing cap. The renal artery or hose feeds the soaker hose or glomerulus, which is permeable. Remember the fenestrated capillaries, allowing almost everything to leak out of the blood into the Bowman's capsule or the bathing cap surrounding it. This filtrate, which is sloshing around in the Bowman's capsule, leaves through the proximal convoluted tubule. See the blue-colored piece of tubule in the diagram to the left above. Let's move on to the next slide. This slide shows a simplified diagram of the nephron on the left and where the nephron is situated in the kidney on the right. The nephron is composed of the glomerulus, the proximal convoluted tubule, the loop of Henle, the distal convoluted tubule, and the collecting duct. The proximal convoluted tubule, which like the glomerulus is located in the renal cortex, becomes the loop of Henle as it extends into the renal medulla. Then the loop of Henle becomes the distal convoluted tubule as it moves back into the renal cortex. The distal tubule becomes the collecting duct as it moves back into the renal medulla, where it dumps its filtrate into the collecting tubule, which brings the urine to the renal pelvis through the renal papilla. Take particular notice of the arrangement of blood vessels surrounding the proximal tubule, the loop of Henle, and the distal convoluted tubule. These blood vessels are both arterial and venous. Notice that these vessels are in intimate proximity to the nephron tubules, and this is where the exchanges between the renal filtrate and blood contents takes place. Now let's move on to the next slide with the simplified diagram of the nephron. Look at the diagram of the nephron again and follow it through as it progresses from the glomerulus to the proximal convoluted tubule, to the descending loop of Henle, to the ascending loop of Henle, to the distal convoluted tubule, to the collecting duct. The filtrate is produced or collected in the glomerulus Bowman's capsule complex and is modified as it moves along to become urine in the collecting duct. So the functional unit of the kidney is the nephron, and the kidney is made up of, on average, about 1 million nephrons. So we need to ask, what is the function of the kidney and why does it exist? The functions of the kidney include maintaining the volume and composition of the extracellular fluid as well as cleansing it, maintaining the acid-base balance in the body fluids, and excreting metabolic wastes and toxins. Let's look at those nephrons again to see what happens to perform the kidney's functions. During filtration in the glomerulus, almost everything comes out of the blood, except the big things like cells and proteins such as antibodies and lipids, unless, of course, the kidneys are diseased. The stuff that comes out normally are electrolytes, glucose, amino acids, bicarbonate ions, which are potassium and chloride ions, wastes, and of course, water. Filtration processes about 125 mils per minute. That's a lot. Remember, 120 mLs is 4 ounces, 4 ounces per minute. All of our extracellular fluid is filtered in about 100 minutes. Therefore, the body's extracellular fluid is filtered about 14 times per day. This is non-selective filtration. Just because it is all filtered doesn't mean that it's all excreted. Remember, the blood vessels surrounding the nephron tubules, well, in these areas, reabsorption occurs. Reabsorption is where about 99% of water, electrolytes, and nutrients are reabsorbed, and the solutes are actively transported back into the blood. This includes electrolytes, amino acids, and glucose. Something to remember, and I will repeat it often, is where sodium goes, water follows. If sodium is filtered out into the filtrate, water follows into the filtrate. If sodium is reabsorbed or transported back into the blood, water typically follows, unless it is blocked. Diuretics work by interfering with the reabsorption process. Active tubular secretion also occurs along the nephron. There are pumps which move organic acids and bases from the plasma to the nephron lumen into the filtrate. These are the wastes, so that we can excrete wastes, drugs, and toxins. Remember the liver and metabolism and the cytochrome P450 enzyme system that changes drugs into more water-soluble compounds, ones that are more readily excreted? Well, this is why, so they can be excreted. A lot of active tubular secretion occurs along the proximal convoluted tubule during the beginning of the journey. In a couple of slides, we will look at where along the nephron reabsorption, diffusion, and secretion take place. This slide shows a diagram of where diuretics work along the nephron. Quickly, mannitol, an osmotic diuretic, works in the proximal tubule. Furosemide or Lasix works at the loop of Henle, hence the name loop diuretics. The thiazides work at the distal convoluted tubule. The triamptorine and spironolactone worked at the distal convoluted tubule and collecting duct. Now let's look more closely at the secretion, diffusion, and reabsorption process along the nephron so we can understand how the diuretics work where they work. In the proximal convoluted tubule, sodium and chloride, once filtered out in the glomerulus, are reabsorbed back into the plasma. Bicarbonate and potassium are also reabsorbed here. Remember, where sodium goes, water follows. So water is taken back into the plasma to maintain isotonicity. As we move to the loop of Henle, we see that the descending loop and the ascending loop. The descending loop is permeable to water. The renal medulla is an area of hypertonicity, meaning it has a lot of solutes or is more concentrated than the renal cortex. So, as the filtrate moves from the renal cortex area to the renal medulla through the permeable descending loop, water leaks out of the filtrate and into the medulla interstitial space due to concentration differences or tonicity. This movement of water out of the filtrate makes the filtrate or urine more concentrated or hyperosmotic. As we move on to the ascending loop of Henle, which is not permeable to water, electrolytes such as sodium and chloride are reabsorbed back into the plasma, and the urine becomes less concentrated or isoosmotic again, no longer hypertonic. Because this section is not permeable to water, where sodium goes, water isn't allowed. In the distal convoluted tubule, the early part of it, sodium and chloride are reabsorbed back into the plasma. And where sodium goes, water follows. In the late distal convoluted tubule, sodium and potassium are exchanged due to aldosterone, and concentration adjustments are made due to antidiuretic hormone. The sodium-potassium exchange occurs due to aldosterone, causing sodium reabsorption via an active pump, and potassium secretion into urine via an active pump. This slide shows where specific diuretics work. Mannitol and acetazolamide along the proximal convoluted tubule, bumetanide, epicretic acid, and furosemide along the ascending loop of Henle, the thiazides and metolazone along the distal convoluted tubule, and amiloride, spironolactone, and triamterene along the late distal convoluted tubule and the collecting duct. This slide again shows where the diuretics work and their mechanisms of action. When you study this, look at it alongside the slide that shows the function of each area of the nephron. For example, in the distal convoluted tubule, sodium and chloride are reabsorbed into the plasma and water follows into the plasma. The thiazides inhibit the reabsorption of sodium and chloride. Therefore, water stays in the tubule and is excreted as urine. In the ascending loop of Henle, which is not permeable to water, sodium and chloride are reabsorbed back into the plasma, making the urine isoosmotic again. The loop diuretics inhibit the sodium chloride potassium transport mechanism, resulting in a hypertonic urine or filtrate, with more sodium chloride and water in the urine. In the distal convoluted tubule and collecting duct, spironolactone antagonizes the effect of aldosterone to inhibit the reabsorption of sodium into the plasma and secretion of potassium into the urine, resulting in less potassium being excreted and more water being excreted. Depending on where the diuretic works, the amount of water it pulls off differs. This is because the amount of water, sodium, and tonicity of the filtrate differs in different areas. As the filtrate moves along the nephron, the earlier stage, the more electrolytes there are to influence. The loop diuretics work early in the journey, so they have a greater effect on water movement. The diuretics that work at the end of the journey don't have the same influence, so they produce less voluminous urine. Let's look at the mechanism of action in general. Most diuretics work by blocking sodium and chloride reabsorption. Where sodium goes, water follows. So if sodium is not reabsorbed into the plasma, neither is water, and water stays in the filtrate or urine. As was stated earlier, if there is more sodium to influence, there will be greater urine production, and less sodium to influence produces less urine. Because of the actions of diuretics, the side effects in general include hypovolemia. If you pull off fluid, less volume is left. If you pull off too much, you end up with hypovolemia or dehydration. Because we are influenced electrolytes, the acid-base balance can be disrupted, as well as the electrolyte balance in the plasma. Here is a quick classification of the diuretics we will look at more closely. The loop diuretics include furosemide or Lasix. Hydrochlorothiazide is one of the thiazides. Mannitol is an osmotic diuretic. And triamterene and spironolactone are potassium-sparing diuretics. Furosemide is the example of loop diuretics. Furosemide works at the loop of Henle, blocking the reabsorption of sodium and chloride ions, preventing the reabsorption of water back into the plasma. Furosemide produces the greatest diuresis of all the diuretics. The onset of action is rapid at about 60 minutes for oral dosing, and the effect lasts about 8 hours. When extensive diuresis is needed immediately, it can be given IV. Uses include pulling off fluid from the lungs in congestive heart failure, general edema due to liver, heart, and kidney failure, and essential hypertension that is not controlled by other diuretics. And furosemide even can promote diuresis during renal failure. The adverse reactions that occur with furosemide include the effect when the drug performs: profound fluid loss and electrolyte depletion. It can lead to low sodium and chloride and dehydration, and as a result, hypotension. In order to prevent the low potassium that may occur, patients are encouraged to eat potassium-rich foods such as bananas, or may be prescribed potassium supplements. There should be some monitoring of electrolytes during therapy. Furosemide can also cause some ototoxicity. Interactions include dysrhythmias when taken with digoxin because of the reduced potassium levels seen with furosemide. Potassium-sparing diuretics can be used with Lasix to help prevent potassium loss. If Lasix should be used with caution when employed with other ototoxic drugs such as aminoglycosides. Moving on to the thiazides, such as hydrochlorothiazide. The mechanism of action is to block sodium and chloride reabsorption in the distal convoluted tubule, which causes sodium and chloride to remain in the filtrate, bringing water into the filtrate, increasing diuresis. The amount of diuresis is less than that seen with loop diuretics. In order for effective diuresis to occur with thiazides, the kidneys need to be functioning properly. If the blood flow to the kidneys is impaired, the effectiveness of thiazides is reduced because of where the thiazides work. Only about 5% of the filtered sodium is reabsorbed in the distal tubule. So if the blood flow to the kidneys is reduced, or better stated, if the glomerular filtration rate is reduced, as in chronic kidney disease, the amount of filtered sodium is reduced and the amount of diuresis is minimal, almost ineffective with thiazides. There are ongoing studies that provide additional information regarding the effectiveness of thiazides in the presence of reduced glomerular filtration rates with differing opinions. Consult current guidelines during prescribing. Hydrochlorothiazide takes effect in about 1 to 2 hours after an oral dose and peaks in 4 to 6 hours. Like furosemide, the last dose of the day should take into consideration the bedtime of the patient, allowing for the effect to wear off before bedtime to prevent nighttime diuresis and interference with sleep. Usually, the last dose of the day should be early afternoon. Hydrochlorothiazide is used to reduce blood pressure and essential hypertension and to reduce edema, when mild or moderate, due to heart failure and liver or kidney disease. The same side effects as seen with loop diuretics occur with thiazides. Dehydration, hypotension, low sodium, chloride, and potassium could all occur. Thiazides do not cause ototoxicity. There is a pharmacogenomics issue with hydrochlorothiazide. Thiazides seem to be particularly effective in blood pressure reduction in those of African descent who have essential hypertension. Therefore, they are the drug of choice in this population. The example for potassium-sparing diuretics is spironolactone or aldactone. The mechanism of spironolactone is to antagonize or block the action of aldosterone at the aldosterone receptor in the distal nephron. The normal effect of aldosterone is to promote sodium reuptake into the plasma, along with water, in exchange for potassium, which is lost in the urine. When spironolactone blocks the aldosterone receptor, the sodium is lost in the urine along with water, and potassium is not excreted, or it is spared. Spironolactone can be used to treat hypertension or edema in combination with another diuretic to help prevent potassium loss. Spironolactone has benefit in cardiovascular issues and has been shown to reduce mortality and hospital admissions. Recently, spironolactone has been studied for several other uses and mechanisms. Let's take a closer look at spironolactone. When you consider the structure of spironolactone, you notice that it is similar to aldosterone, a mineralocorticoid steroid hormone. That is why it can sit in the aldosterone receptor and block it. Spironolactone structure is also similar to other steroid hormones, such as testosterone and dihydrotestosterone. Because of this, spironolactone can block the effects of androgenic hormones and has been used to treat acne, hair loss, and hirsutism in women. Recently, spironolactone has been looked at for its influence on the immune system. Now that we are aware of the structural similarities of spironolactone to steroid hormones, we can understand some of the side effects. In addition to the possibility of hyperkalemia due to blockade of aldosterone, spironolactone can also cause gynecomastia, menstrual irregularities, impotence, hirsutism, and deepening of the voice. The elevation of potassium can be significant, and a plasma level of potassium greater than 5 milliequivalents per liter can lead to dysrhythmias that can be fatal. Therefore, with signs or symptoms of arrhythmias or elevated lab values, spironolactone should be discontinued. Spironolactone, because it prevents potassium loss, is used in combination with thiazide and loop diuretics to counteract the issue of potassium loss. Caution should be taken to avoid salt substitutes that use potassium when using spironolactone. Potassium supplements should be avoided in the absence of labs dictating their need. There are some drugs that suppress the secretion of aldosterone, such as ACE inhibitors, angiotensin receptor blockers, and direct renin inhibitors. Avoid using these drugs along with spironolactone. Triamterene is a potassium-sparing diuretic, but it is not an aldosterone antagonist. The mechanism of triamterene is to directly inhibit the sodium-potassium exchange in the distal nephron. It reduces sodium reabsorption and reduces potassium loss into the urine. The end result is mild loss of water. Triamterene is used to treat hypertension, edema, and in combination with other diuretics to counteract potassium loss. Triamterene is available in a fixed combination with hydrochlorothiazide and the product diazide. The adverse reactions attributed to triamterene include nausea, vomiting, leg cramps, and dizziness. Blood dyscrasias are sometimes seen. When used in combination with other potassium-sparing diuretics, potassium supplements, salt substitutes containing potassium, diets high in potassium-rich foods such as bananas, broccoli, orange juice, and spinach, and ACE inhibitors, angiotensin receptor blockers, and direct renin inhibitors, hyperkalemia can occur. Amiloride is similar to triamterene. It also blocks the sodium-potassium exchange, resulting in loss of sodium water and reduced loss of potassium. Amiloride is used to counteract the potassium loss of other diuretics. The adverse reaction is that it is too effective in preventing potassium loss, resulting in hyperkalemia. Let's talk a little bit about hyperkalemia. The normal range for plasma potassium is 3.6 to 5.1 or 5.2 milliequivalents per liter. The range can be from 3.5 or 3.6 to 5.1 or 5.2. When the potassium level exceeds 5.5 milliequivalents per liter, it is considered hyperkalemia. With hyperkalemia, initially, membranes become more easily excited, but when it becomes refractory, but then it becomes refractory and less likely to fully depolarize. Some patients are asymptomatic at this level. Others exhibit symptoms of nausea, vomiting, diarrhea, abdominal pain, irregular heartbeat, whether it's fast or slow, muscle fatigue, numbness, and tingling. This usually occurs because of drug interactions. Hypokalemia, on the other hand, produces symptoms that are just as serious and needs to be addressed also. Hypokalemia is considered a plasma level of less than 3.5 milliequivalent per liter. That is why diuretics that promote potassium loss need the addition of potassium supplements or potassium-sparing drugs. The symptoms of hypokalemia include weakness and fatigue, constipation, muscle pain, and chest palpitations. Psychiatric symptoms can also be seen, such as psychosis, delirium, depression, and hallucinations. These result from the lack of potassium, changing the resting membrane potential, requiring a larger stimulus to generate an action potential. Typical agents implicated in potassium loss are the thiazide and loop diuretics, amphotericin B, and cisplatin. The bottom line is, it is important to maintain normal potassium levels. Drug interactions that occur with all diuretics include additive antihypertensive actions. Nonsteroidal anti-inflammatory drugs reduce the efficacy of all diuretics because they inhibit prostaglandins and bradykinins, producing renal vasoconstriction, resulting in reduced blood flow to the glomerulus and reduced filtration. ACE inhibitors reduce potassium losses, so the risk of hyperkalemia is increased when the combination of potassium-sparing diuretics occurs. Hydrochlorothiazide reduces the elimination of lithium, and diuretics, by virtue of removing fluid, can affect lithium concentration. Monitoring lithium levels is warranted. Aminoglycosides cause ototoxicity, which is additive with loop diuretics. Sometimes diuretics are misused, such as when they are taken for rapid weight loss, such as if athletes must make the weight class, or to reduce puffiness to fit into clothing and possibly improve physical performance. Use caution with requests for diuretics for non-clinical